Good afternoon, everyone. To begin with, I would like to thank the organizers, Team Mindray, particularly Shama, for getting me again on this platform. Today, I would be covering the approach to diagnosis of hemolytic anemias through a few cases. We begin with our CBC, which shows low hemoglobin for the age, sex, and race as defined. And so the patient is having anemia. And how does this happen? To put it simply, this could be because of decreased production of RBCs, as we see in nutritional anemias, or in bone marrow suppression, as in aplastic anemias, or it could be due to the increased destruction of RBCs, as in the case of hemolytic anemias. And this is going to be the focus of my talk today. So the central investigation, CBC, showing anemia. On PBS, what we see is polychromasia and specific cell abnormalities. We need to do the reticulocyte count, reticulocyte production index, and we need to take this in account with the clinical findings and the biochemical findings. In the clinical picture, what we are looking at is the history with particular reference to the age, family history, past and recent history of blood transfusion, and so on. In the clinical features, we are looking at pallor, jaundice, hepatosplenomegaly. In the biochemical findings, what we are particularly concerned with is the increased serum indirect bilirubin, increased serum lactate dehydrogenase, and decreased or absent serum haptoglobin. But coming back to our CBC, what does it tell us? So in cases of anemia, traditionally we have been classifying them as microcytic, normocytic, and macrocytic. The microcytic hemolytic anemias are the thalassemias. Other than that, what we see in hemolytic anemia is typically a normocytic to mild macrocytic picture, along with an increased RDW. On the peripheral blood smear, what we can make out is significant polychromasia, as we can see in this picture here. Very hard to miss. And when we see polychromasia on the smear, the primary differential, though, is hemolysis. We should also consider early response to hematinics, acute blood loss, and bone marrow stimulation. The other abnormalities on the peripheral blood smear, we should look for cells like target cells, sickle cells, schistocytes, spherocytes, marked red cell agglutination, which would give us a direction towards the diagnosis of the hemolytic anemia. So our investigation comprises all these features put together, as can be seen here in the slide. While preparing for this presentation, I went through a few articles which gave us a methodical approach or an algorithm to the diagnosis of anemia, in particular hemolytic anemias. And I found this one particular article from De Gruyter quite interesting, where they have classified anemias based on the reticulocyte production index. Anemia with RPI of more than 2% was defined as anemia with reticulocytosis and further worked up. Initially, early response to hematinics was ruled out. Then they went on to do the DCT to rule out immune-mediated hemolytic anemias, and went on to review the peripheral blood smear for RBC morphology and the specific types of poikilocytes like spherocytes, elliptocytes, stomatocytes, sickle cells, or schistocytes directed the further investigation of the anemia. The types of hemolytic anemias are the hereditary and the acquired. Now, the hereditary would be the anemias which have something to do within the RBCs typically. So these are the thalassemias and hemoglobinopathies affecting the hemoglobin within the RBCs, the red cell enzymes, and the red cell membrane defects. So typically the intracorpuscular defects. The acquired causes of the hemolytic anemias are where something else comes and sits on top of the RBCs and destroys them. So these include the immune-mediated hemolytic anemias, drug toxin-induced, mechanical stress, and microangiopathic hemolytic anemias. Paroxysmal nocturnal hemoglobinuria, I would say, sits on the cusp of intra and extracorpuscular, though it is an acquired genetic disorder associated with complement-mediated lysis due to abnormal cell membrane proteins. I will quickly go through a few cases. Like I mentioned, microcytic anemias, in case of hemolytic anemias, should alert you towards the thalassemias. So this is a 33 years female who had come for an ANC workup to us on on the CBC. We had a hemoglobin of 10.4% gram percent, microcytic hyperchromic indices, a relatively low RDW and high RBC count. We could see target cells on the peripheral blood smear. Ferritin was near normal and the Menser index was 11.34, suggested a diagnosis of heterozygous beta thalassemia. So we did the HB-HPLC, which revealed a concentration of HbA to 5.2%. So this was a case of heterozygous beta thalassemia. Definitive diagnosis would involve family studies and molecular studies. This was an 11 months female child, severe anemia, very wide RDW. The RBC histogram shows a very wide distribution starting from the race from the baseline. Microcytic hypochromic indices, peripheral blood smear likewise is showing marked anisopoikilocytosis with the presence of polychromasia, target cells, NRBCs. We did the HPLC, which showed HbF concentration of 93.2%, suggestive of a homozygous beta thalassemia. Again, confirmatory test would be the family studies and DNA study. 5 years male child presented with anemia, 7.3 gram percent, normocytic normochromic indices. However, we see a wide RDW of 23.1%. Peripheral smear, what we saw was the moderate anisopoikilocytosis with few sickle cells and target cells. HB-HPLC showed an S window of 82.1%, suggestive of homozygous sickle cell disease, again to be confirmed by family studies and DNA studies. The next case is that of a 1.5 years male child. Luckily, it was our OPD patient. We could get some history in this case. There was a history of repeated infections since birth with presence of pallor and icterus, presence of hepatomegaly, no splenomegaly, and indirect hyperbilirubinemia. Again, the CBC showed hemoglobin of 7.3 gram percent. The indices were relatively normocytic for this age group of 1.5 years. However, the RDW was increased 22%. And the peripheral blood smear showed anisopoikilocytosis with the presence of polychromasia, RBC fragments, microspherocytes, and these cells which are giving an impression of bite cells. So male child bite cells, we were thinking of G6PD deficiency. We did the G6PD assay, which showed that G6PD activity was reduced. The rest of the workup was normal. And we came to a diagnosis of G6PD deficiency. It's an X-linked recessive disorder. Another non-specific screening test for enzyme defects would be the demonstration of Heinz bodies by supravital staining, as can be seen in this image. However, in this case, we had done the red cell enzyme assay. For the confirmation would be by molecular and family studies. The next case is that of a 3 years male child who was referred to a lab for hemolytic anemia workup. In low hemoglobin with wide RDW. RBC indices were more or less normocytic for this age group, I would say, mild microcytic. And the peripheral blood smear showed the presence of spherocytes with polychromasia, increased reticulocyte count. We did the osmotic fragility test in this case, which was increased. Rest of the workup was normal. So we suggested a diagnosis of hereditary spherocytosis in this case. The osmotic fragility test, acidified glycerol lysis, autohemolysis are the non-specific tests used in these cases. However, specific diagnosis would be by membrane protein analysis, molecular and family studies. The red cell membrane proteins typically involved are spectrin and chirin, pallidin, stomata, glycophorin. So this way we covered the hereditary hemolytic anemias, thalassemia, sickle cell disease, the red cell enzyme defects as in G6PD, or the membrane defects as in hereditary spherocytosis. Here we come with next case. This is a 17 years female presented with complaints of fever with rash and generalized weakness, hemoglobin of 6.2 gram%, normocytic normochromic indices, however, a wide RDW again. The peripheral blood smear showed moderate anisocytosis with mild polychromasia, could see some reactive lymphocytes and occasional microspherocytes. Retic count was increased. We did the osmotic fragility test, which was increased in this case, and they had done a serum protein electrophoresis, which showed a marked increase in gamma globulins. So we asked for a DCT looking at the peripheral smear. The DCT was positive by both the gel card. We also confirmed it with a manual tube agglutination technique, and an autoantibody workup followed. So ANA was positive. Anti-DNS DNA was positive by immunofluorescence, as can be seen in this image. And so was the ANA blot positive for an RNP, SM, and ribosomal P protein. So we came to a diagnosis of autoimmune hemolytic anemia associated with systemic lupus erythematosus. The next case, 83 years male patient had come to the lab for a regular checkup. What we saw was a hemoglobin was normal, but an MCHC of 89.7, and which gave us a review flag. H&H check had failed. We saw the smear in which we could see RBC agglutinates. So the RBC count was fall slow. We could see a review flag for both WBCs and the platelets. We reran the CBC after incubation at 37 degrees Celsius. So with incubation, the RBC agglutinates disappeared, the count came back to normal, so did the hematocrit and MCHC, and the peripheral blood smear picture, as can be seen to the image on the right. Direct Coombs test was positive, a cold agglutinin test was positive with a significant titer of 1 in 128. So this was a case of autoimmune hemolytic anemia, cold agglutinin positive. So broadly, autoimmune hemolytic anemias would have warm antibody, cold antibodies. They are frequently associated with lymphomas, infectious mononucleosis, or atypical or mycoplasma pneumonia infections. The workup consists of that direct antiglobulin test, initially using a polyspecific broad spectrum reagent, followed by monospecific sera to identify the types, and other investigation to find out the underlying cause for autoimmunity. The next case, this was 81 years male patient. He had a history of mitral valve replacement with prosthetic valve around 25 years back, was on oral anticoagulant warfarin since then. He had presented to our lab with an episode of hemoglobinuria 6 years back and has been on follow-up with us for persistent anemia. So this was his cell counter report. Hemoglobin of 8.1%, mild macrocytosis, RDW was low at this point in time. However, peripheral blood smear did show the presence of 1 to 2 schistocytes per oil immersion field. Typically, during the acute episodes of hemolysis, he has shown a wider RDW. So this was a case of prosthetic heart valve-induced mechanical injury, hemolytic anemia. Another such case, 11 years old male child, had a history of fever and diarrhea since 2 to 3 days and referred for CBC and urine routine. On CBC, we had a low hemoglobin, typically normocytic indices, a wide RDW of 23.4% CV, and the low platelet count. Peripheral blood smear showed polychromasia with the presence of schistocytes. The urine routine had revealed 3+ proteinuria with 20 to 25 RBCs per high power field with a raised creatinine. Here we are considering a possibility of hemolytic uremic syndrome in the case of microangiopathic hemolytic anemia. Whenever schistocytes are present above 1%, it is considered significance. And if that is the dominant feature, then a possibility of microangiopathic or mechanical hemolytic anemia is to be considered. With this, I would like you to take through our data over the last 5 years. So what we have seen is somewhere between 25 to 30% of our CBCs, I would say, showed anemia, low HB. I tried to go through the data. I took all CBCs with a hemoglobin of less than 11 gram percent, significant anemia with RDW of more than 18%. And within this population, MCV somewhere between 80 to 105 femtoliters. So normocytic to mild macrocytic picture with a wide RDW. So about 10% cases. So the cases in purple, about 10% cases of our total. So these would probably require more attention from the respect of hemolytic anemias. I am not saying these would be hemolytic anemias. There would be hemolytic anemias falling in other populations, and there would be other anemias or anemias on hematinic therapy falling within this population, but these should be given more attention. And vis-a-vis this count, we had only doubled to 100 to 150 reticulocytes being done in these cases. Again, want to bring out the same thing that we also have anemia profiles, hemolytic, anemia profile mini, predominantly for nutritional anemias and retic count, but very few retic counts and anemia profiles as such are requested in our practice. So what I would just bring out with this data is the incidence of anemia in routine practice remains high. However, what we see is reticulocyte count has been inadequately ordered in routine private practice, though it has been an important test in the diagnostic algorithm of anemias. Though we are talking about the advanced reticulocyte parameters today. What does the cell counter still not provide us? It is the presence or extent of poikilocytosis. So PBS remains an important tool in the investigation of hemolytic anemias. But can we combine some RBC parameters on the CBC to steer us in the right direction towards the diagnosis of hemolytic anemias? Like I had tried to bring out the population in purple. Of course, I was not considering the microcytic anemias, which include the thalassemias. They have been extensively dealt with previously. With this, I would like to thank my team and thank you all for patient listening, and would be happy to take any questions.